All right. As always, we like to record these info shares to be able to post on YouTube should there be any questions. And you can, and you miss it or you want to refer back to something, you can always check out our YouTube channel. You are joining us for the February 2024 Provider Info Share. And we're really going to be going over a lot of the same stuff that was covered in the care coordinator info share earlier this month. So if you have follow-up questions based on that session, you're welcome to drop them into the chat. But what's happening? The Full Lives Conference is coming up in a couple of weeks, and we are so excited to get as many people participating in Full Lives as possible. And there's a couple of different ways that you could participate. You could participate as a presenter. And how could you do that? Well, we are going to be accepting proposals up to tomorrow afternoon for presenters at the Full Lives Conference. So if you have something innovative that your agency's doing, something that's unique or a practice you think's important to share with our community, please consider putting in a proposal. This year's Full Lives Conference has the theme Inclusion Lives Here. And we know that you as providers are really you're really making that inclusion happen, and you're creative about it and have come up with so many different ways to make that happen over the course of a lot of interesting times with the pandemic and transitioning out of the pandemic. So again, please consider putting in a proposal. There are other deadlines coming up related to Full Lives that we really want to put on your radar, and one of them is training access funds. So the conference is held in Anchorage, and it's going to be at the Sheraton Hotel, and it will not be virtual this year. So that is a big kind of shift from what we've had happen for the past couple of years. Well, we don't want this to exclude anyone that's in our rural communities, so we ask that you consider applying for training access funds. Please do that. The application deadline is coming up on February 28th. So if you are interested in attending just as an attendee, you don't have to be a presenter, but just to attend and learn from your peers and from other Alaskans, please consider applying for travel funds. And then finally, one of the big, most celebrated components of the Full Life Conference is the award for our DSPs. We have 6 different categories, including one for care coordination. And so this is really an opportunity to highlight a direct service professional that is going above and beyond in what they do, that's creative, that's that has a special skill set that really makes them stand out as a direct service professional. Consider nominating them. You can do that by March 6th, 5 p.m., so that we have an opportunity to celebrate our direct service professionals and care coordinators at this conference. So those are the big Full Lives components that we wanted to just start off with and talk about. Is there anything that I missed, training team, that you think we need to make sure our provider agencies are aware of? I did it. I covered it. Well, just in case, if you weren't in the care coordinator info share, the SDS training team does offer renewal training opportunities from the Full Lives Conference, and we'll keep you really in the know on the details of that, and that's upcoming. So with that, we do have, oh, go ahead, Heidi or Margaret.
Oh, sorry.
It's okay.
I just have a quick question. I don't know how to lower my hand. Okay, sorry. I was gonna ask you, it's a great segue. Is anybody doing anything at Full Lives on how to sorry, how to better utilize technology in care coordination. Because I feel like we're doing a lot of like training elderly people on Zoom, and I feel like there's probably I mean, I have some handouts from my agency, but I'm just wondering if like there's anybody that has, I don't know, like a little. I'm old, so if I want to know how something really works, I'm like asking my teenagers. But I feel like there's probably somebody young and hip that knows a lot more about technology, and I just think that would be a really helpful piece. I don't know, just an idea.
Thank you so much for bringing that up, Heidi, because it was brought up a lot during kind of brainstorming on proposals. Um, Technology in many different ways, because you're right, it's changing so fast and it's really can be leveraged in a lot of different ways. There's this whole thing called AI. I don't that people are like trying to wrap their heads around because it can do more than make background pictures, which, people think like AI does art, but it also can do, people are looking at how it can be maximized for different things like case management and records and different pieces like that. Um, do we have like a proposal, a class prepared for full lives? I'm not sure yet, but it's something that's on the minds of the collective. What I would encourage from you all to think about is if that's something that your agency has really started to leverage different technology resources or ways to connect Alaskans distance delivery. Like, are you using innovative distance delivery practices? Are you using interesting software techniques or AI? Feel free to put in a proposal to showcase those kind of innovations, because that's the sort of collaboration and peer-to-peer experiences we want to have at Full Lives, where people can share um, the cutting edge, so to speak. Because I feel you, it's happening so fast, and it's hard to keep things running just the way they are and learn how new things can support it. So hopefully we'll have something for you, but I'm not sure what. We get the proposals tomorrow and we'll know from there. So once we have an idea, hopefully next session we get together, we'll have an answer for you. Awesome. Kara, would you talk with us a bit about HIPAA? Because there was a couple of situations that came about in the past few weeks, and we wanted to talk about HIPAA and when you're working with client lists in different capacities, in different instances where you might have a list of Alaskans with private health information.
Sure. Yeah, I can do that. Hang on just one second. And I'm going to finish this email because I can't think of that and write an email at somebody's trying to get in to
Oh,
the,
someone's trying to get into the session.
yeah.
Yeah, we want
Okay.
everyone in, so we'll
Kara,
get.
let me
All
take
right.
care
I've
of
sent
that.
it. No, I got
Okay.
it. I just
She's
did.
getting people connected. Thank you for that, Kara.
Sure. Okay. Yeah, for the HIPAA part, sometimes we get involved in, like communications where there's a lot of people, something concerning a group of people, and some of the people we serve are on that list. And it really depends on what, it depends on your role. Um, but we don't want to share entire lists of people when we're trying to answer emails like that. Um, it- Private health information for the people we serve is everything about them. So a person's name, their initials, um, of course, anything to do with their treatment strategies or anything where you could infer a diagnosis and or an economic level. And so just by virtue of being qualified for our services, these are all inferences that one can make about a person if they know one of those pieces of information. So that's why it's all HIPAA protected. You want to make sure that if you need to get work done for a person, that whoever you're connecting with is somebody who has a need to know, to get a specific task done for that person. You have permission from that person to release the particular information you're releasing, or talking about or writing about to that person. And if there are other names or other forms of private health information attached that are either for that person or anybody else, then you're going to want to get rid of that. So you could use redaction where you black it out, or you could just, just take out the pertinent information and give it to a person who has a need to know. The basics of HIPAA beyond, I mean, everybody pretty much knows it's protected health information. But the basics of it are, it's only certain information that you have permission to share. The person is knowledgeable of that and has given you agreement to share it, and it covers each instance, or the person understands about the instances by which it will be shared. Like, it's not shared forever and ever. It's for a particular purpose, the purpose of a support plan, the purpose of a question, the purpose of eligibility. As long as the person understands that it's not shared forever without any reason, and they've signed a document like that or given you agreement like that, it is for the purpose of doing business for that person, then it would be permitted, but not blended with other people's information at all. So we know there's just been a few cases where a lot of people were affected by something that happened with the provider, for example. But we don't want to, just because you got something and it may have other information on it like that doesn't mean that it's a-okay to go ahead and share it. It's up to you to protect it. Like, each one of us is responsible for that. So if you get something like that and it doesn't look like it was, followed, if the rules weren't followed, then you're not going to repeat it yourself just because you got it like that. Even if you get it from somebody who, I guess, for lack of a better way of putting it, should know better, like another provider or state, you know. Does that get it? Did I get it, Delight?
Yeah, I think so.
Sound
I
okay?
think it this is kind of tricky because it's like, well, give me an example, right? Like, what are we talking about? Tangible example. Like, perhaps there's a situation where a residential, like a assisted living facility has a list of clients, and then they um, provide that list to a care coordinator to like note somebody on the list, like, oh, they didn't get their medication or something like that. That document really needs to be redacted, especially if you use that information to then submit to SDS something where it's like, this person is on this list, or they're affiliated with this certain thing and there are other people on the list. Because what happens is when you file something like that in Harmony, you're then kind of cross contaminating their Harmony file with other people's PHI. So so it seems silly because you're like, oh, I've got to file this document in John Smith's file and this document in Jane Doe's file, and it's the same document, it's the same people, they had some kind of altercation or something like that. You would redact the people's names that are not affiliated with the file because we're keeping their Harmony file just to that person's information.
And there's a question.
Yeah, go
Go
for it.
ahead.
Sorry, it's Heidi again. I learned how to raise my hand. Ha ha ha. I'm just kidding. I'm unstoppable. No, but one of the things that I had come across recently is where another provider, like it was a chiropractor, like the family was trying to submit something to DPA, and it showed like they had to show proof that the previous medical providers had been billed, was one of the DPA requirements. So the family got this thing from the provider, but it said the client's name and then another person's name that's not related, and they CC'd me on it, and I was like, I didn't know what to do at that point. Like, it wasn't a direct, it wasn't anything that I solicited, and I didn't pass it along, but I was CC'd on it. So I don't know. I just redacted it and saved the corrected copy to my client's file, so there wasn't anybody else's information in there. But I don't know if I should have like sent it to somebody or done something with it. So
Needed the correct protocol is to fix it for your records and then reach back to the person that sent it and say, you know, to the effect, you've provided me with content that you've with personal information, personal health information that's not related to my case, to my client. And it's then on that provider, that other person, that other entity, they're going to need to take their proactions of letting their client know they have to do a release. But that's where it's like kind of it's tricky because you received it, but as long as you save it so that it's correct, so that it's just your client's information, I would make a note to file to the record saying that that happened and keeping those kind of documenting that it happened is enough. Just keeping that record. I don't know if I'm just thinking about food safety, but like the cross contamination of data into people's files, it's just really a matter of keeping people's health information related to them. And that concept Kara was talking about of really it's only we're only need to know basis only when you're working on that information. If you get something in error, delete it, redact it, and then contact the sender and let them know that you received the wrong information.
That's good. I'm going to put in a Harmony. If you ever come across HIPAA concerns in Harmony, like what you're talking about, if there's, you get into a file and I'm just talking about those of us who have access to Harmony. Some of us don't in this session. But if you are one and you find information that doesn't pertain to the person in there, somebody else's PHI, you can always give us a notice. And I just put in the DSM address for that.
Thank you. And just for all providers, all we're saying, like if you take anything away from this session on HIPAA, take away the idea, be careful with lists of people's information. How are you sharing that information? What do people need to know on that list of information? Because chances are high that they don't need all of it because we only share and work with the appropriate channels with the information that we need to. So just be careful with working with large lists. So that takes us to number 3, which is related to Harmony, and it's specific to CFC applications. So this does impact personal care agencies as well. So both care coordinators and personal care agencies, they file applications in Harmony. And when we have situations where there's multiple applications, like a waiver and CFC, or a PCS agency is preparing to submit a application, please keep in mind that applications need to be separated from each other and filed in the correct Harmony program note, the right notes. So CFC applications have their own application note, waiver applications have their own note, and PCS applications have their own note. They all have to be separated because they all go to different places and people in Harmony. So why is this news? Well, over the evolution of time of Harmony, at one point it was okay to combine them, but we've changed that practice for a couple of years now. They've been separated, and we need you to keep them separated in Harmony so that they go to the right places. And that's really the big updates that we have. We do have some reminders. I don't know if Kara or Cassandra want to go through those for you all.
I could take the reminders. So under reminders, we have the individual and family quarter information sharing webinars series. And here's the link to join. And if you look below, you'll see the different dates starting in March that they will be held, March 26th, June 25th, September 24th, and December the 31st. And those times are from noon to 1, okay? Please keep those in mind and share them with your families and your individuals, because that is the time where they could come to us and ask us questions if they have any questions, and maybe you have questions for them. I mean, for us, for them, you know, they may not know how to ask the questions, and you're more than welcome to come in and join along with them while they speak with us. Also, we have provider monthly info sharing, and that registration link is right here as well. The webinars, but all of these are on Zoom now. So even though we got webinars here, they are all on Zoom. So please remember to tell your cohorts that we have switched from GoToMeetings or GoToWebinar into our Zoom account so that they could come in and get the new Zoom links, or reach out to us and get the new Zoom links, and you can share them with them as well. We have all 12 sessions going on through the end of the year, and if you look below, you'll see the dates there, and it's from 2 to 3 p.m. So please take note of that, and again, take note that the place of holding the Zooms has changed from webinar, from GoTo to Zoom, okay? Do you want me to go through the resources? Well, here's all of our resources down here. We got our provider office hours on Thursdays, 3 to 4 p.m., which is on Zoom as well. Please come out and join us if you have any questions, or if you just have a problem that you just cannot figure out how to get answers for. We're there for you. If it's more than one person, we'll break out into Zoom rooms. Give us a moment. Some days it's nobody there. Some days everybody come at one time. So just please be patient with us while we get to each person. And if you notice that you're in the waiting room a little bit too long, or just what, send us an email so that we may have to work with you one-on-one at another time, because we are just that busy at that moment. But please be patient with us. We have individual and family office hours every other Monday, starting February 5th from 12 to 1, which I just spoke about. And here's our SDS training YouTube channel. If you just need some information, go to our YouTube channel. You may see different videos about different things, or it may not necessarily, it's not a CEH, but it's information that you just may have a small question. It could be something about harmony. It could be about person center, or I can't think of all the other little videos that's up there, but it's a couple of different things that's out there. And so just go to their YouTube channel. Someone just wrote me this morning to let me know they saw our CIR on a YouTube, but now since they watched the video, they wanted to take the training. So a lot of the things like that are out there on our YouTube channel. Policy also has a YouTube channel, and here's their link for it as well. And then here's our Training Academy e-think link, which we call our Training Academy. You hear me say, go to our Training Academy to do XYZ, and it could be CEHs, it could be your recertification, settings, CIR, the CFC stuff. It's a lot of different things that may be there, and we're building more and more courses in there. So please, if you haven't signed up for our Training Academy, do so that you can get some of your trainings done. And I believe that's about it. Thank you.
Thanks, Cassandra. I think the only thing I wanted to make sure we were all really clear on was the difference between a quarterly family web session, informational session, and the office hours. And then Kara, did you want to talk about that since you do the eligibility training on the quarterly session?
Sure. The eligibility training is just an intro about eligibility. Like one of the big questions that we get from people, our Alaskans, who are interested or potentially could use services is, how am I eligible and what does that look like? And what are some different options? So we do a training about that, which is, it's informal, so it's a quick training and some conversation. A lot of times we end up encouraging folks to go to the ADRC or to not literally go, but they can call, or interact with the ADRC because they have different needs for care that are, outside of the question of what is eligibility. So there's that, and the other one for office hours is just for questions. We really don't have an agenda for that. And sometimes people come in and say, "Well, I'm here for the training," but it's we're happy to answer. They just need to come in and, let us know what's on their mind, or at least give us a few things to talk about. We don't have like a set lecture for that. So it's more listening and giving information, custom. So
Awesome. Thank you. Guys, that's really what we had for you today for the agenda. There's no rules that we have to stay all the way to the top of the hour, but we do want to give you time for asking any questions or have any comments that you might have that's really that your agency is facing at this time. So we'll open the floor to you all, and you're welcome to either chat it into the chat or you can unmute yourself. Either way is fine.
okay, a question says, could we give more definition on the care coordinator assistant role?
Oh, sure. This is a really exciting new role in Harmony. It's called the HDEA. So that's the Harmony Data Entry Assistant. It's a new role for agencies to essentially set up somebody whose sole responsibility is Harmony data entry. And in the process of setting up this role, there's a couple of key things that we just need to put on the table for you all. One of them, number one, an HDEA, a data entry assistant, is not a care coordinator. That role is it's not intended to take on the job of care coordination. It's supposed to help people, help care coordinators and agencies track deadlines, maybe do typing in of demographic information, submit missing signature pages, and do administrative type tasks. While plan development, getting to know the family, really connecting with them to be able to build a plan that fits their needs, working with agencies, that is still care coordinators' work. The intention is to really set up the care coordinators so that they can spend more direct time providing care coordination, and the work of typing, date tracking, and that administrative documentation element is supported by this role. So with that in mind, that's the purpose of the role, its scope. It is, if you're going to decide your agency would like an HDA in there, you're going to have to hire them like you would any other person in your agency. So you'll have to complete background checks. Your agency may have to get workers' compensation insurance if you're a CC agency of one. You may have to get workers' compensation insurance to be able to to hire another person. And they'll have to go through the Intro to Harmony process and being added into Harmony by having a access coordinator turn in their individual user agreement into the Harmony data system. So hopefully that gives some clarity, the scoop on it. I think there's probably one of the more important considerations for an HDA is that even if they work as a HDA for an agency, it doesn't in and of itself count as care coordinator experience. Their background in education may be may meet that care coordinator experience, but just working the role as an HDA wouldn't necessarily count as care coordinator experience if that person chose to progress their career going into care coordination. Good question.
Other thoughts or questions from the group? Okay, the question says, when do COVID restrictions get lifted regarding visits? You know, there hasn't really, it's been murky, and we've followed the lead of you know, our overarching public health directives, throwing it back a few years. There isn't a restriction on visits per COVID. People can receive face-to-face visits if that is what they are preferring. It's sort of morphed and changed to a regulatory requirement for one face-to-face visit every 6 months, and for care coordination, and one face-to-face visit within a service, within a waiver service. It's sort of changed from the idea of COVID restrictions to that over the years. I think if you're asking when does our PHE end, then the answer to that is July. Help me out, Delight. July.
So we are expecting that the flexibilities will be ending July 1st. So that's the target date. And you'll be seeing quite a bit of information coming up in the next 2 weeks on it, because an SDS is preparing all of the messaging for it as far as frequently asked questions. But with that in mind, do you have questions about when the flexibilities end? Because we can make sure those are on the table for frequently asked questions, and that we try to make sure those learning needs are captured. Is there anything that you're nervous about when the flexibilities end? Go for it, Heidi.
Heidi with the hand. I'm just kidding. See, this is why I can't learn new technology. I overuse it.
Oh, no, that's not a bad thing.
I don't think there's anything that I'm nervous about, but I do think it would be really nice to have it all outlined in the FAQs, because I feel like I just had to ask it on the care coordination webpage. I was like, I can't remember. Did Dayhab in different locations get extended or not? Or did only part of it? And then I was like driving myself crazy, and then I couldn't find anything on it. So then I just asked the group, and I got an answer. I'm not sure 100% that it's the right answer. So I think the neurotic vibe of care coordinators is that we need it clearly delineated so that we don't drive ourselves crazy and over ask, or like, I don't know, just like perseverate on it. Like, did we do it right? Did we put it in the plan right? Is it going to get kicked back? Because that's what stresses me out. Is like, did I not remember it correctly?
Oh, and I'm going to ask that we all have some grace for each other through this process, because it's been very confusing. Because over time, certain things started as a flexibility, became permanent, or we messaged something was going to happen because we were sure it was going to end. And so everyone had this perception that it would end, and then it didn't. And so we have a lot of points on very specific flexibilities that are murky. They're very murky, and it's really it's a collective reason. And so definitely give yourself some grace and knowing you're not losing it. I'm not sure anybody's had it. Like, it's just been very fluid and it's been changing. So don't feel like you're asking too many questions on it, because we'd rather you ask the question and try to dial in what needs to be taken care of as we transition out of this. Because there's some cases, very specific cases, where it's going to take a lot of explanation because they've never had waiver services outside of the COVID experience. So then we're having to explain legally responsible individuals are no longer allowed to offer this service. Like, they are allowed to do it in this one, they are in that one, but not this one. That is going to be very confusing. So we're really trying to open channels and make sure we have these family office hours too, because you may need help with some of those kind of conversations because of just the way things have happened with the course of operating during a pandemic. So a couple of questions. So hopefully I'm trying to give you guys I'm trying to empower you to ask, but know that the resources are coming and we're thinking it through. The resources that are coming for sure are very clear on what ends in July. So it's a very these are the things that stop in July. That doesn't cover some of these things that have happened in the past that people are going to get confused by. So it's really tricky. It's going to be tricky for a while, but you're not, we're all in it together, honestly. And we'll just have to work through it together.
There's a couple questions here. I'll start. Regarding the coming change in visits, specifically 6 months face-to-face. A question: what happens when a care coordinator makes an honest mistake and fails to make a visit at the 6 month from the last face-to-face? Would the care coordinator be required to pay back the previous 5 months of billing? Would the care coordinator receive a reprimand from QA, or what would happen? What should the agency admin do to protect themselves and the care coordinator from this kind of mistake? Okay, so, then there's another one. In 6 months, is that a 6-month cycle of the first visit to the next, or is it from 2 set dates by the state? Okay, so my thought on this is, where's the regulation describes minimums. It's not really set out for us to think about it and slice and dice it like that in terms of the experience in care coordination by the person. Some people will need more help than that. It is not to be expected that that's it. It describes a minimum. The pieces about audit results, if you fail to make a visit, I can't confidently say yes or no to that, because when you get audited, the auditors are looking for if care coordination was done and if regs were followed. Okay, so if you followed regs and if you did care coordination, then it was done. If you followed part of the regs and didn't do the whole thing, then care coordination wouldn't have been done. So payback and stuff like that is entirely custom results that are during that, audit process. The 6-month question is I can tell you that it's probably not a good idea, to do a year's worth of visits face to face, and only those, one of them on, July. I don't remember if July has 31 days right now or whatever, but one of them on June 30th and the next one on July 1st, right? And call it a year, because care coordination is throughout the year. It has a monthly unit. It has a monthly set of tasks that are described in regulation that you do. There is not a date that's set out by which they have to come, that they have to happen. It's a monthly unit of care coordination, largely informed by the needs of your person, with the bare minimums that are described in regulation. And if any provider doesn't do what's regulatory required, of course they run the risk of audit and they run the risk of payback. But I can't be specific to it. Like that's a jar that's opened in a whole other set of circumstances. I can't be specific to it here now today, other than as the trainer, what folks with audits are looking for is, has care coordination been done? Let's look at the regs. Were the minimums followed? Yes or no? And the way to avoid it, I think, would be to come to meetings like this and to know that this is how it's supposed to happen. To have open lines of communication to the people you serve and to be diligent about visits and don't wait till the last minute. Get it so that people expect you at a certain time and they're trusting that and they're ready to be with you and they're ready to, let you help them. And to look at it that way as opposed to, well, what am I going to get in trouble for if I don't do it? That type of thing.
Yeah, I think that's great. That, you dialed into exactly what I was thinking about is part of your initial intake or planning for a year should include how would you like to communicate and work with your care coordinator this year? And like just ask them that, like knowing that, letting them know that I have to see you a couple of times a year. When's a good time for that? And putting that choice for people, because if you place it on you, you're going to be in this situation where you're like, gosh, I need to meet up with them. And they're like, oh, I'm at fish camp. Do you want to come see me? I'm I'm in the middle of nowhere. Good luck finding me. Here's the GPS coordinates. So consider setting up your communication plan with each other at the start of this plan year so that it's really clear. You can set your calendar reminders of like, all right, everybody's home in March. We can see them in March. They know we're coming. We can plan it so that we see each other. And similarly with other different like service environments, making sure that you're all aware of like when you're going to be making those visits so that it's clear for the person and they have control over that dynamic. That would be my recommendation for you on how to avoid it. If you're at the tail end and you're like, oh gosh, I didn't do it, first step is contact the person to set up when you're going to see them. Like that's your remediation right away. Like don't wait for an audit 3 years from now. Make a case note, like reviewing case file, overdue on personal contact, called client, scheduled personal contact. And so it's really clear when you figured it out, what you did, and actually go meet the person. So that would be my like encouragement for you.
This is Heidi. I think that's a really great point, Delight. I think where it comes into issue is like when you've traveled, you spent like $5,000 to get to Kodiak, for example, to do your every 6 months in-person visit, and a client had to be medevaced. Like that's something beyond anybody's control. You had a planned meeting. Then what do you do? Incur another $5,000 bill the next month to go back and see that one client? Like that's the part that it's going to be, there's going to be a little bit of and then do I just pay back the 5 months, to say, well, I wasn't able to meet them in month 6. I think that's kind of the logistical question. Of course, we try to visit more than that, but sometimes the locations, or if you only have 3 clients, it's super cost prohibitive to always, like some of the places we go, we have to charter a plane into. And like we, really can't justify that expense for one client because they ended up in the hospital. Or so I'm like, and I'm not trying to be difficult. I'm just saying like these are things that we have to kind of think about too as care coordinators when we're asked by the state or contacted like, hey, can you take this client in Timbuktu and there's only going to be one person there. Like that's I guess
Mhm.
kind of a tough business decision, but it's just something to think about.
Mhm.
No, thank you
Yeah,
for
I get
that.
it.
Yeah, thank
Mhm.
you.
Some of that happens too if when people die, you know, they unexpectedly pass away. And this is why I'm not able to say that you have to pay back in all situations in all cases, because there could be best faith efforts made on the part of the care coordinator and they document it fully, and then they go on about serving the person with care coordination, and then an audit is done and they have their findings. I don't think that, you know, it happens 100% of the time, depending on what's going on with that client. But like I said, I can't speak to it because it's so situational, like what you were just talking about. Go ahead.
Yeah, your best practice is to document the situations. Document the plan. When are you guys going to see each other? Did you see each other? What happens if you didn't see each other? Like that's something too to consider is, if someone, and it does happen, like they are avoiding seeing you, you like that's a whole conversation. Are they missing? Like you have to go through all these different parameters of trying to figure out and trying, like the care coordination is coming in and like trying to contact, make sure they're safe, connecting with them. Someone gets medevaced, you're going to have records that show that, you're going to have your plane tickets and the dynamics of rescheduling it and finding it out. You'll have to just do your best. And that's really all that any of us can do. We are a rural, remote state, and this is part of our work that's complicated.
Hmm.
I agree. But I mean, I guess I see it a little different because you do have 6 months to just see a person once in person. So, I mean, I hear everything everyone is saying, but you have 6 months, half of a year to try to see this client one time in
Hmm.
person.
And if we get involved with folks that are, you know, have a lot of needs and different kinds of situations going on, please just let SDS help you. It could be unit staff, could be us, it could be probably more likely our leadership team and unit staff who's helping with the scenario where it's like, oh, we've got an individual living in a rural community and they really need this. Will you do it? You know, who will do it? Those are situations where there's just going to be so much documentation flowing from the whole situation where, you know, it's not going to be regarded as the same as like, well, we just didn't do care coordination, we can't tell what was done. You know, that's a lot of what catches people in audits is like there's no other supporting documentation to show that care coordination was done. It's not the kind of situation you're talking about where people are pulling strings and making efforts to have something happen, you know. Anyway, really great questions and discussion. There is a question here from a provider about daily respite. It says, is daily respite 12 to 24 hours of care relief for the primary caregiver? So yeah, primary caregiver is an unpaid um, primary caregiver, and daily respite is done either in the person's home or in a licensed home, you know, like a licensed assisted living place, which is the licensing matches the person, meaning like for adults or for kids and the population type. It is 12 to 24 hours of care, and 24 hours of care is somewhat nebulous, but it is 12 to 24 hours of care that typically encompasses the usual sleep time that the person has. So it's a day if they sleep there and they say overnight. I know a lot of people don't sleep at night and stuff like that, but the person's usual sleep. So it would be minimally 12 hours and at the most 24 hours encompassing the person's usual sleep time, and it's of all providers combined. I hope that helps.
So let's compare what's the other type of respite? Because
Hourly respite. That's up to 12 hours of respite as approved in the support plan to relieve an unpaid caregiver of providing care. and it could be done anywhere. It doesn't have to be done at home. When I say it's done either in the person's own home or in a facility, a licensed facility home, it doesn't mean they have to stay home all day. It just means that that's where they are for that, living there for that time period. Hourly respite can be done anywhere, and it's for the same purpose: give the caregiver a break. It's authorized in the plan. Usually we see, since we ask that plans give a minimum weekly average, we usually see 10 hours a week as like a weekly average, but it doesn't have to be used like that necessarily with respite. It is possible for people to request more respite given the circumstances through their care coordinator. It's one of the services that people can request more if something is happening and more is needed.
Awesome. I think what some people are a little startled by when there's a request from what SDS may ask about for respite is SDS does ask, like, they ask kind of questions like, well, what does the primary caregiver do that the provider is going to do in place? So that's part of the request. You want to make sure, like as a planning team, that the respite provider understands what kind of care and support the person needs when providing respite. So it's for the primary caregiver, but there's an ask of, well, not necessarily like I guess the ask really is, what will the respite provider do to support the person so that that's documented in the plan and that can make sure that person's needs are met.
Mm-hmm.
Good
Great
questions. Yeah. Well, we're winding up to the top of the hour, the end of our time together. But if you have more questions, you're welcome to drop them in or unmute yourself.
And if you think of one later, if you're like me, I'm like, oh, I should have asked that. You can always email us at sdstraining@alaska.gov, and we'll answer your question. And we can also call if the office hours and things like that aren't working for you and you need us to call. Just give us some good times and days and we'll do that, or set up a Zoom. We just throw those out as kind of like buckets where we're there, we're open, we're at our posts ready to help. But if you need us at a different time, then just reach out, just ask. Okay, Harmony assistant role. Does it have requirements? Can anyone be placed as a Harmony data assistant? The person has to be an employee and they have to be well, they have to be have a user agreement filled out by your care coordinator admin. So it doesn't, they don't have to have credentials of a care coordinator. They have to apply as a user. They have to have a user agreement. They have to be with your agency. They have to have a user agreement turned in. They have to take Intro to Harmony, and we have to know which care coordinator they're working with so that we make sure that they have access to the right people in Harmony. That's all. That's what I'm trying to get at. And it's per agency, as I understand. It turns out to be, like per care coordinator. I think I had a question once where it was like, well, can I be that for a bunch of care coordinators that aren't in the same, more than one care coordinator that aren't the same agency? And I believe the answer to that was that you had to do it twice, once through one agency and once through the other. So because of that, it's per care coordinator.
Yes, you're correct. So you wouldn't have to take Intro to Harmony multiple times, but
right.
The access coordinator for each agency would have to submit separate documents, and you'd have to be an employee, or like some people do volunteer work. Either way, you'd have to comply with your agency's protocols on hiring and background checks, and the agency would have to have insurance.
Mhm. All right. I don't see any other hands up or questions coming in. As
Thank-
always, we'll post this on our YouTube. Sorry.
Yeah, go
You
for
go
it.
to our your YouTube channel, like and subscribe for notifications of when we post new videos. And yeah, thank you so much, everybody, for joining us today.
Yeah. And we could yield back 3 minutes of your time.
Yeah.
Hopefully you can go outside and enjoy these tropical winds that we're having in Anchorage. It's a hint of spring that we very much need. Um, all right. Have a good one.
Thanks, everybody. Bye for now.